Good afternoon, everyone. It's my pleasure to be here at the All India Ophthalmic Conference. I'll get you back to the basic skills of lamellar keratoplasty from the nuances of the femtosecond. Basically, we'll be just trying to see the lamellar keratoplasty, concentrating more on the correct depth of lamellar keratoplasty and how we can achieve it. I have no financial disclosures to make. All right. Again, lamellar keratoplasty depends on the level of stromal separation which we can make. We can either have an anterior lamellar keratoplasty depending upon the depth of the lesion, or we can have a deep anterior lamellar keratoplasty, which is essentially a Descemet's bearing one, and which involves the total stromal removal. Most important criteria for removal would obviously be a corneal opacity, which spares the Descemet's membrane, and grossly distorted corneal topography, which precludes the use of contact lenses. And in our practice, the most common indication would be keratoconus, which is obviously very advanced, and it has to have an adequate endothelial function and obviously a very healthy ocular surface. Again, these are the common indications for which need lamellar keratoplasty. Most common, as I told you, is keratoconus. Steps are quite simple. It involves the separation of the anterior stromal fibers. We can have various methods, in fact, and the deep dissection of the posterior stromal fibers is very essential. And the next step would involve the preparation of the donor corneal button, and then it involves suturing of this button to the host bed. 4 simple steps. And the success of DLK actually depends primarily on the separation of the stromal fibers from the Descemet's membrane, that is the deeper layers, because this is where we can have perforations and cause complications. And as I told you, the perforation and its management is very paramount to get a very good post-operative outcome. Most commonly used method, of course, is the big bubble, or the separation of the lamellar fibers by usage of air. Now, how do we know if we are in the correct plane or no? If we are quite superficial, this is a kind of bubble which we get. It's not exactly a bubble, but just a separation, but just the air fibers just traveling in the various stromal layers, and it can get into the anterior chamber as well through the trabecular meshwork and cause this kind of a picture. And with this, it's quite difficult to separate the Descemet's from the posteriormost stromal fibers. Now, what is it we want to achieve? We want to achieve create or get a perfect big bubble wherein the separation of the posteriormost stromal fibers from the Descemet's occur. I'll just show you a video as to how the correct big bubble has to be achieved. We just mark the partial stromal cornea and then just use the air, and that's the one which is in the right plane. Once the big bubble is achieved, we just remove the anterior stromal fibers. All very simple instruments used, which we normally use for cataract. Then the residual stromal bed, we just nick it and then separate it carefully from the Descemet's membrane, taking care not to perforate it, just ensuring that it's separated all over, and we remove the posteriormost stromal fibers, leaving behind only the Descemet's. And injection of the air ensures that its Descemet's is intact, which is actually not necessary to do. Now we remove the donor endothelium from the stroma, and then this is sutured onto the host bed. Perforation can even occur at this point of time if we are not careful and if we pass the suture's full thickness. So care should be taken to suture the partial thickness of the stroma. End result would appear somewhat like this. Now recently we've got the OCT incorporation in the microscope itself, which can give us the gauge of the depth, and this is the surgeon's view as to how it can be seen. And the surgeon sees the partial thickness or the profile view of the cornea, and that's an advantage, and this is how it appears. We can use it for both the anterior as well as the posterior lamellar keratoplasty. Advantages is that it's real-time imaging and top-quality intra-op OCT visualization can be seen. And most importantly, the continuous OCT scanning intraoperatively helps to improve the treatment results. The surgeon can make better decisions during surgery. And this is one example of the surgery which we did, and just carefully note that this is an advanced keratoconus, and focus your eyes on this point, and that is the corneal scar which involves, that is actually as a result of post-eye drops, and the scar is one which is full thickness there. But many of you would differ from me to go ahead and do a full thickness keratoplasty, but this kid being just about 16 years of age, we always prefer to have his own endothelium, and we still went ahead and did deep interlamellar keratoplasty. I'll just show you the video of that particular surgery. Alright, we just take about 8 millimeters marking, anterolamellar dissection using the 600 microns precision knife. I'm just removing carefully the anterior lamella. I do only a guarded big bubble, not a full big bubble, because I know there's a scar there which can lead to perforation. So just you saw only a limited big bubble, and I'm removing the posterior-most stromal fibers very carefully, but then just see there's a perforation at the site of the presence of the scar there, right, which is very easily visible in the OCT. And see how the spawn swells up. Now we are left with a dilemma as to whether to continue with the DALC or convert it to a full thickness. But we prefer to proceed with the anterolamellar keratoplasty. We just peel the decimates of the donor carefully, which we can also use for the DMEC if the quality is quite good. We go ahead and suture the anterior lamella onto the host cornea, but still look at it. There is non-opposition of the graft in that particular place where there was perforation. Now we need to oppose that. We take the help of intracameral C3F8. Now look at that. Once we've injected it, the adherence is quite good. Look at the graft adherence after the injection of the C3F8. We make sure to remove it the very next day. And this is the first post-operative day, and look at the cornea, pretty clear, except I'm not sure if you're able to visualize the area of perforation, which is quite sealed now, and the profile view shows the clear cornea, and we've succeeded in proceeding with the lamellar keratoplasty itself, and unaided visual acuity 6/24. This is the OCT picture, which shows a clear cornea, and most importantly an adhered cornea. So there lies the importance of proceeding with the deep anterolamellar keratoplasty. Despite complications, if we can manage to continue and succeed in a lamellar keratoplasty, that would be far superior to doing a full thickness keratoplasty. This is another case where we can take the help of an OCT guided microscope. This is the pre-op photo of pseudophakic bullous keratopathy who came with an uncorrected visual acuity of just finger counting 1 meter. This is the OCT picture of it. Just look at the gross stromal edema. The previous surgeon who had done a cataract surgery had gone quite deep into the stroma while doing the cataract surgery. And this is the video of the decimate stripping endothelial keratoplasty. We've done the manual variety. Just note the gross stromal edema there. We mark the customary 8 millimeters trephine partial thickness, enter into the anterior chamber and try to strip the decimates membrane, just removing the epithelium for sake of clarity. We do the desmetorrhexis, preferably under the air. You can also do under the saline irrigation. Once it's removed, we can prepare the donor graft. Again, I'm removing the epithelium for the sake of clarity. This is on the AC maintainer. Again, I use the 600 micron guarded knife. Now look at the OCT picture there. You need to be as close to the decimates as possible. We prefer to do an ultra thin dissect, which is less than about 120 to 130 microns. Once the donor is prepared, we insert the graft and unfold it I use the saline at times and I use the air as well. Look at it, it's still not adhered. Look at the OCT picture. Despite using saline, it doesn't adhere. That's when we use the bubble, simple injection of air, which ensures adequate adherence of the graft. This is a great relief for the surgeon because at the end of the procedure we are sure the graft is adhered. Otherwise we have tantalizing times post-operatively and we think whether the graft is attached or not until the time we wait for the first post-operative day. This is the post-op day 1 picture of this particular patient. From finger counting 1 meter, it has improved to 6/12 uncorrected. And look at the adherence of the posterior lamella. It's pretty clear. It's a simple procedure, doesn't involve expensive instruments. If done manually, can give wonderful results. This is the OCT picture of it. And this being a manual decimate stripping endothelial keratoplasty, you can see the slight disparity in the thickness of the posterior stroma. Despite that, it gives wonderful results. Thank you so much.